Coming to us via online stream is Dr. Simon Gibbs, who is feeling really sad that he's unable to be here in person thanks to COVID-19 in Melbourne. Dr. Gibbs is a consultant hematologist and amyloidosis lead at the Department of Clinical Haematology Eastern Health, director of the Victorian and Tasmanian Amyloidosis Service, a founding member of the Australian Amyloidosis Network, and honorary senior lecturer at Monash University. We want this evening to be all about you. We will have a question and answer session after their presentation, so please feel free to ask away afterwards. The only stupid question is the question that is never asked. Gentlemen, the floor is yours.
Fantastic. Well, thanks very much everyone for asking me to present to this exciting workshop. I am extremely sorry that I can't be there. I'm sure it's an anti-Victorian thing. Remember, Scott Morrison is actually from New South Wales, not from Victoria, and I apologise for our Prime Minister, and I've said this to several New Zealanders on many occasions actually, that we're very happy to swap leaders at any time. Let me see if I can share my screen now. So I've been asked to talk about what is amyloidosis, and in particular talk about ATTR and go over some of the treatments. So first of all, what is amyloidosis? Well, basically amyloidosis is kinky proteins. Anyone with amyloid have got proteins that are a bit kinky. So they are proteins that misfold and then stick together and make a very hard wax-like substance, almost like a concrete. And in fact, it comes from the Latin and the Greek meaning starch-like, so quite hard. So proteins themselves are small molecules that we all have, and they help like biological processes. So your genes will tell you to make proteins from amino acids, and these proteins will have all sorts of different roles in life, such as making antibodies as part of our immune system to fight infection, to produce hormones that regulate our body's growth and organ function. And it's the way that the proteins are folded is really quite important as to how well they are going to be able to do that function. And when they are folded properly, they work well. The problem with amyloidosis is when these proteins start to kink or misfold, and then they assemble abnormally. So when we look at amyloidosis, this hard wax that's made from misfolded proteins, it depends on which proteins have actually kinked in the first place to determine the type. And the type will often dictate which organs are involved and what treatments we need to use. So I'll be talking about the Transthyretin types today. Regardless, what we often have as clinicians is that we're faced with a patient who comes in and says, I feel pretty rough, I've got vague symptoms like new breathlessness, I've got numb fingers and toes, I've got some weight loss of appetite, feel lightheaded, I mentioned the breathlessness, swollen legs, or we might pick up that they've got some excess protein in the urine or an irregular heartbeat. So because these are common and vague symptoms, we don't often think about amyloidosis as our first cause. So often it will take some time for things to be delayed, and it can involve a number of different organs such as the kidneys, the heart, the nervous system, and the gastrointestinal tract. When we do make the diagnosis, we need to work out, is this amyloid just in one spot? Is it just a little bit of protein that's made from locally produced abnormal kinked proteins, or is it actually in the bloodstream that's circulating? So it's localised and systemic. Localised is pretty rare, but the prognosis is excellent and doesn't usually require any treatment. So it's really important that we distinguish between those two. And it can also be hereditary and acquired type. So acquired, it occurs spontaneously, often as we age, or hereditary is that we've inherited some faulty genes from our parents. And I mentioned that the type of amyloidosis will determine the prognosis of the treatment. So it's important that we work this out when we are first faced with a patient with amyloidosis. So I'm often asked, well, how common is this? Well, a lot of people say this is a rare condition, Peter Millay, who's speaking after me, did a great study that looked at what the incidence in Australia seems to be. We think that probably about 300 Australians are diagnosed with AL amyloidosis every year. I'm sorry I don't have the New Zealand data on that, but we believe that up to 10,000 Australians have ATTR. This has been a really underdiagnosed condition, and it's only in the last couple of years that we've realised how common it actually is. Regardless of the type, we know that it is more common in adults aged over 50 years of age, and tragically it's more common in males. Symptoms are non-specific, as I mentioned, and so the diagnosis can be missed. And we know that there are certain risks that will mean that you're more likely to develop amyloidosis. So if your bone marrow, the body's factory for blood cells, produces too many immune light chains, then you may be at risk of having the AL form. We know that if you have a family history of amyloidosis, brothers, sisters, aunts, uncles, parents, then you're more likely to have it as well. If you have chronic infections or inflammatory autoimmune diseases, you're more likely to have the secondary AA type. And tragically, as we get older, we're all at risk of getting the ATTR. It does seem to be a disorder of aging. And I mentioned that as a consequence of increased awareness, we're actually seeing a significant increase in the diagnosis of ATTR, and that probably also reflects our ageing population. And the diagnosis is delayed, and this is important, and I think some of you in the audience will probably only know this too well, that many of our patients will have symptoms for 1, 2, or even more than 3 years before they're actually diagnosed. And most patients will see more than 3 doctors before they actually get a diagnosis. And the diagnosing physician is often a haematologist, which reflects what I consider to be the more intelligent specialty within medicine. I'm a bit biased. When we think a patient has amyloidosis, we often will take a biopsy. Insoluble configuration, which we call amyloid fibrils. It's a bit like having a 4-leaf clover can fall apart and the leaves can misfold and stick together. But when we look at treating, we're actually increasingly going back to the gene that's actually making the TTR in the first place. Can we actually stop the production of TTR? Do we actually need so much TTR in our system? And we can live perfectly well with 90% of our TTR not being there. So we know that we can knock this down. So what we try and do is we have these drugs called gene silencers. We try and turn the genes off so we stop making the protein that makes the amyloid. And there's a number of trials that are going on and some that are finished which show that these molecules have great promise and seem to be highly effective and well tolerated. Then what we can actually do is that we can stabilise the 4-leaf clover so that the leaves don't fall off. So we call these TTR stabilisers. You may have heard of drugs such as Diflunisal and Tafamidis, and the new kid on the block is something called Acoramidis or AG10, which I believe some of the New Zealand sites have actually had that trial open as well as Australia, and it looks very promising so far. We can also try and disrupt the fibrils, so when those misfolded proteins stick together, using Doxycycline, which is an old antibiotic, and even green tea extracts called EGCG. Lastly, the holy grail really is to try and take the amyloid out of the heart, if we can. There is a potential treatment, but those trials seem to have been significantly delayed, which always spells a bit of trouble. But watch this space. We can attack this disease from various angles. So let's start with Diflunisal. So Diflunisal, it's an old anti-inflammatory drug, but it was shown in a test tube that it can actually stabilise the 4-leaf clover and stop it from falling apart into individual units. And there was a trial, what called placebo double-blind study, where half the patients got the real drug and half got the dummy drug, a sugar pill. And what that demonstrated is that patients who are on the Diflunisal, they were on the anti-inflammatory TTR stabiliser, their nerve problems didn't progress as much, their quality of life didn't deteriorate as quickly, and in actual fact it was really quite well tolerated. So I always watch the kidney function, the blood tests, And because it can upset the stomach, always take it with some food, and it's usually given twice a day. If we look at Tafamidis, this is the one that's got a lot of press. So Diflunisal costs $1 a day. I've had a patient in Australia who has been buying this privately and he's been paying $12. Have a look at a test tube. Compared to Tafamidis and Diflunisal and AG10, what's really interesting is that in actual fact Tafamidis, there are reports that Tafamidis is slightly weaker than Diflunisal, despite the fact that it's got a much higher price tag. If we then have a look at AG10, that looks particularly beneficial. Patisiran I've mentioned, so Patisiran is the genes areas. We saw that there was stabilisation of cardiac function. It was, as I mentioned, very, very well tolerated. If you have a look, that there was double the number of patients on Patisiran than on placebo, and what we found was that the rate of death was better in the Patisiran than the placebo. Not thought to be due to the study drug. If we look at inotersen, which is a competitor agent, we also saw that there was a significantly a statistically significant difference between those at 8 months and 15 months. We saw that patients did not deteriorate as quickly on the inotersen, and that also equated to an improvement in quality of life as well. Doxycycline, I'll just mention briefly. So this is an old antibiotic which definitely seems to... Green tea has been reported mainly by the Germans as potentially halting progression, slowing progression. You need to have the tablets because otherwise you need to drink 2 litres of the stuff every day. I wouldn't advise doing that. We've treated about 80 patients with this because it's cheap and easy to access. The only problem is it can cause some liver dysfunction in very high doses. So we don't recommend very high doses, just up to 600 milligrams. The other form of treatment I just wanted to touch on, which I think, again, as doctors, we do really badly at emphasising, and that is, the free stuff that you can do yourself. So the 3 Ds are the diet, diuretics, and daily weight. So the diet, low or no salt. Okay, diuretics and daily weight. So the diet, low or no salt. Okay, don't have it on the dining table, don't add it to food. Salt means you'll retain more fluid. You should be on a fluid restriction as well if you've got a lot of fluid retention, and to weigh yourself every morning. If you're starting to do so, because patients will often come home and I'm not hungry, I don't have an appetite, I feel full already. So you might eat quite well at breakfast, but it's still sitting in your stomach by dinner time, so you don't feel like dinner. So domperidone helps to push food through the stomach, take it before meals, and often you find you'll be able to eat a little bit more. And maybe take some supplements like sustagen, so things that are easy to digest, so build up shakes, etc., etc. Speaking to your dietitian can help. If you have low blood pressure or dizziness upon standing, I think midodrine's a really good drug, and they can help boost up the blood pressure. And we've got lots and lots of different things for diarrhea. We can bind people up, we just need to be able to take enough, and people are scared to take too much. Also, dietary modifications are important. Obviously, caffeine can irritate the bowels from spicy food, so if you have diarrhea, back off from those. And we have a number of treatments for those who have cramping, nerve pains, etc. So please let the doctors know if you have these symptoms and insist that they be treated appropriately. Last but not least, I'd encourage any of you to check out the Australian Amyloidosis Network's website, which is amyloidosis.net.au. There's lots of different bits of information on there. And I think that this cartoon on YouTube called Amyloidosis Awareness is really, really helpful. It goes through some of the things that I've mentioned today. And also the Amyloidosis Research Consortium does some online booklets, which I think are really, really helpful. And I would ask you to check those out. But that's my presentation. I just want to again thank the organisers for asking me to speak, and I'm happy to answer any questions after Peter's talk. Thanks very much.